So are we about ready to start?
Okay, we're live now.
All right. Well, I'll offer another good morning to everyone. Please sit back and relax and enjoy this next hour or so that we have our distinguished guest, Dr. Groesbeck Parham. And for those of you who joined just a few minutes earlier, I know that he, has connections all over the world. My name is Janine Payne, and I'm joined by Cheryl Thompson. We are co-executive directors at the Institute for the Advancement of Women's Health, building trust in the delivery of evidence-based health research to enhance a woman's decision-making around care. We welcome each of you to the Saturday Morning Lounge, and thank you for rising up with us at 8:30. And in Dr. Parham's case, he is about 2:30 or so, 2:35 or so. That's there. Right. All right. So he has the afternoon. He's already started his morning. But today, Groesbeck Parham, MD, joins us from Lusaka, Zambia, where thankfully it is earlier than 8:30. But Dr. Parham is world known for his work in HIV and women's cancers. And for that reason alone, I know that it's important that we start now with one request. If you know Dr. Parham personally, if you can jot into the chat your name and perhaps where you met. So for recall, that would be great, because after he finishes the presentation, what Cheryl and I would like to do is just read a few greetings to him. In addition, as Dr. Parham is going through his presentation, if you could include any questions that you have in the chat box, and he may pause throughout his presentation. However, it'd be very helpful to us if you also include your questions in the chat. Also, any information that is shared today we don't want it to replace information that you should be receiving from your healthcare professional. So if there's something of interest to you and you feel that you need to do a little bit more questions and answers, please seek that advice from your healthcare professional. So I have the distinct pleasure of introducing Dr. Groesbeck Parham. Dr. Parham is a U.S. board certified gynecologic oncologist. He is a graduate of Oberlin College, 1970, and the University of Alabama School of Medicine, where he was the first African-American obstetrics and gynecology resident in 1985, and a gynecologic oncology fellow of the University of California, Irvine, 1988. While by the World Health Organization and the United Nations as a leading authority on building cancer care systems in resource-poor settings. Dr. Parham is currently professor of gynecologic oncology in the Department of Obstetrics and Gynecology at the University of North Carolina at Chapel Hill and the University of Zambia. He moved to Lusaka, Zambia in 2005 to help establish the country's cervical cancer prevention program. Parham would learn that cervical cancer in Africa was not only a medical problem, but a disease reflective of the deep state of poverty and powerlessness that the vast majority of women in sub-Saharan Africa negotiate on a daily basis. Just a little perspective. Women in sub-Saharan Africa face a triple burden of communicable diseases such as HIV and tuberculosis, non-communicable diseases such as cervical cancer and breast cancer, and a high risk of death during pregnancy. When women in Africa die, it impacts the survivorship of their young children. It goes without saying that Dr. Parham is a leader in cervical cancer prevention in resource-constrained settings. His team was the first to provide cervical screening and treatment services on a broad scale to HIV-infected women in sub-Saharan Africa. His program is now the largest in Africa, having screened more than 1.5 million women for cervical cancer across Zambia. His work with the Zambian Ministry of Health extends to strategies for nationwide human papilloma virus, HPV, vaccine for young girls, and the introduction of breast cancer screening and treatment services in primary healthcare facilities. Most recently, he assembled a team of African American surgical oncologists who have trained surgeons in Malawi, Zambia, and the Democratic Republic of the Congo to treat cervical and breast cancer. He was awarded the Society for Gynecologic Oncology's Humanitarianism Award for his work on cervical cancer and selfless dedication to improving the lives of women in Africa. It is the same selfless dedication that earned Dr. Parham that award, that placed a yes on his heart when we asked him to join this group in the Saturday morning lounge. Dr. Parham, the floor is all yours, and thank you, and good morning again. Good afternoon.
Thank you. Thank you, Janine, for such a great introduction. And I want to thank you and Cheryl Thompson in the Institute for the Advancement of Women's Health for inviting me to this Zoom presentation and giving me a chance to talk and to learn and to interact and to see old friends. I see Linda Clayton is there and Tom Porter's there and many others. And I want to give a special shout out to the National Association of Negro Business and Professional Women's Clubs Incorporated. And I look forward to meeting you when COVID is over and I make another trip back to Washington, D.C. But it's great to be here. And what I wanted to do was just, Cheryl and Janine asked me to talk about this epidemic of women's cancers in Africa. And so I wanted to start with just to try to personalize it a little bit, to tell you a little about Zambia, which is in the southern eastern part of sub-Saharan Africa, how I got there and what we've been able to do so far. And then I can go back and give you some statistics about this epidemic of cancer that seems to be sweeping across Africa and all other low and middle income countries or settings in the world, and maybe talk about the causes of it and maybe what some of the things we may be able to do about it. So, and you can stop me along the way and ask questions if you like. Then at the end of the talk, we can talk more. So next slide. Can you hear me okay?
We can hear you well.
Yes. Are your slides showing?
Yes. So, okay, you can go to the next slide.
Okay, let me advance.
So as I said, Zambia is a country of about 18 million people. The capital city is Lusaka. It's landlocked. It's surrounded by 8 international borders, other countries, Angola, Namibia, Botswana, Zimbabwe. It was very important during the South African ANC battle against apartheid. It was the home to the ANC, and there are many streets and roads that are named after ANC leaders. Kenneth Kaunda was the president during that time, and Zambia took some heavy hits, and the hospitals were bombed and a lot of the public facilities because they provided refuge for members of the ANC during their battle against apartheid in the 40s, 50s, 60s. So it's a very interesting place. About 40% of the people are moving into the largest cities, which are in Lusaka, in an area called the Copper Belt. You'll see something about that in a minute. But about 60% of the people are still living in rural areas. The median age is the same as that in most African countries. And most African countries have very young populations. It's changing a little bit as the economies get better, but people on the continent, until recently just didn't really live a long time. And HIV/AIDS crisis sort of lowered that age, the average age of survival. When I first got into Zambia, the average age of survival, I think, was around 48 years. And now it's up to about 60. The adult literacy rate is about 85%. For women, it's about 60. And it has a raging, has had an HIV pandemic for years. For women, it's about 14% prevalence, HIV prevalence. Overall is 12.3. And there are pockets in the city and areas around the country where the HIV prevalence hovers around 25%. Obviously, it's much higher for commercial sex workers. So there are about 1 million people living right now with HIV. And the two most prevalent cancers in females, which was the same thing you'll find in this region of Africa, sub-Saharan Africa that I'm showing you, is cancer of the cervix and cancer of the breast. However, that's changing now a bit as the economies tend to become quote unquote more liberalized, and people begin to pursue the westernized type of living. You begin to see cancers that are more prevalent in the West, such as, again, breast, colon, prostate, etc., cancers of the lining of the uterus. So next slide. Next slide, Cheryl. So the economy in Zambia is based primarily on mining. I think it has the second or third largest deposits of copper in the world, and probably the second or third largest deposits of emeralds in the world. It's big in agriculture also. Now, obviously, somewhere in the 80s and 90s, when Zambia, under the orders of the International Monetary Fund, underwent this liberalization process, the ownership of the copper mines, it was privatized. And so the country really doesn't benefit from the taxation and the ownership of those very rich mineral deposits as much as it should, because about 2/3 of the Zambian population actually lives on less than $1 a day. And it took me a long time to believe that, but as I've lived here long and longer, I've realized that it's the truth, and you can see it. You can see it every day. It's just amazing how people have been able to live under these conditions for such a long time. But it's reflected in many of the diseases that people have and the shortened lifespans. And in rural areas, still, most of the people don't have running water or electricity. So, I tell my grandkids all the time, you think you got it bad. You don't even know you have no idea what bad is. People in the United States you can't compare situations a lot, but I'm telling you, we are blessed in so many ways. Anyway, next slide. So that's sort of a bird's eye view of Lusaka. Like I say, 2.5 million people. It's probably closer to 3 million people now, but it's a pretty densely populated area. Houses are packed. And the next slide, I'm going to show you the average dwelling quarters of people who live around Lusaka, the masses of people. Next slide. And so that's it. And most of these places don't have, some will have, there will be a tap, a communal tap, where you have to, go and get your water. People still bathe in foot tubs, and so there are no real sewer systems that have been developed. So you can quite understand that the rates of things like cholera are still a problem. That's an old infectious disease that was solved in the United States decades ago with the development of sewer systems. You can't live around your waste products. But this is a problem that still exists in sub-Saharan Africa and in parts of India, China, et cetera, you know, in the developing world, even though we know how to solve these problems. But this is the average dwelling, and most of the women that we reach out to and screen for cervical cancer and breast cancer come out of these kind of dwellings. Next slide. And, you know, it's hand to mouth. You know, it was very interesting when the government tried to quarantine people here in Zambia. It just didn't work, because if you're making $1 or $2 a day, you're making that because you're out on the street hustling something. And so if you try to keep people inside, they're not going to make that money, whether it's cassava, tomatoes, you know, whatever it is people are trying to sell to make $2 or $3 a day to survive. So it's been difficult to quarantine people, just like you've seen in South Africa. It's really difficult to quarantine people who live in these settings, because they just have to get out and try to make a living. Next slide. So this is a typical communal tap in some of the peri-urban areas in Zambia and out in rural areas. You'll just see this. It's very common. Next slide. So when I visited Zambia first in 2003, I was at the University of Alabama at the time and visited. I had someone introduced me to a friend, a guy who later became my friend, who was running from the University of Alabama, was a young doctor. And he was heading up a very large HIV treatment program. This is when the money started coming from the US President's Emergency Fund for AIDS Relief to provide free drugs for men, women, and children in sub-Saharan Africa and other countries in the world that were at high risk. So, you know, my interest as a gynecologic cancer surgeon obviously was cancer of the cervix. So I wanted to meet colleagues who worked at the University Teaching Hospital. So this is where I visited, and I eventually set up my first cervical cancer screening clinic in this facility. But this was the maternity ward for the tertiary hospital in the country. And they deliver anywhere from 15 to 17,000 women a year in this place. Lots of maternal deaths still, shortages of blood, shortages of anesthesia. It's gotten better. You know, my hats always go off to the African doctors and African nurses who struggle against just almost damn near insurmountable odds to try to deliver high quality healthcare to the men, women, and children in these countries. They're really heroes and heroines, and I have the greatest respect for them. And you really don't understand what it takes to work as a physician in these environments until you get in and get on the ground and sort of join in as a member of the troops. Next slide. And this is at the University Teaching Hospital in Lusaka, Zambia. And so one of the things I found out, I'm sorry, go back, Cheryl, to the previous slide. No, there's one in between that. Yeah, go to the next one. Okay, go back, I'm sorry. So, you know, I got there and actually it looked a little better. It looked worse than this because at the time you could barely walk through this is the gynecology ward at that hospital. You could barely walk through the wards because there were two people in each bed. There were women all on the floor because the HIV crisis. Women were in the hospital sick. And so I just started asking questions. I said, you know, most of these women are young, and why are they here? And I was told that 80% of the women on the gynecology ward had invasive cancer of the cervix. Now that probably used to be true in the United States in the 40s and 50s, but then the pap smear came, and over the next 20, 30 years, the rates of cervical cancer dropped significantly in the Western world. Well, there was no cervical cancer screening here. So what I was doing was looking back in time to what was in the United States or the Western world 40 years prior. Now, I had seen some of this when I was training as a resident in Alabama, because there are these very poor areas in Alabama Black Belt. And I used to see, women coming in, dragging a leg because one of their nerves had been paralyzed because it was compressed by cervical cancer. But I had never seen it on such a massive scale in such young women. Because, cervical cancer is a disease you get when you're 45, 50, 55 in the US. These women were in their 20s and 30s. And so my question was, why is it that you have so many women not with just cervical cancer, but young, they're young. And, the thinking at the time was maybe it was HIV that made a contribution to the this virus that we know that causes cervical cancer becoming more predominant and progressing from a viral infection to pre-cancer to invasive cancer at a much more rapid rate. Whereas it may take 20 to 25 years in a woman who's not infected with HIV and a woman who's infected with HIV, particularly if she's severely immunosuppressed, and a lot of these women weren't taking anti-HIV drugs at the time, that thing can proliferate. And in 5 years, they're dead from the time they get an HPV infection to the time they develop a cervical cancer that's growing into their bladders and rectum and metastasizing to the lungs and occasionally the liver. So we did a research project. I was able to get $25,000, and Linda Clayton would tell you there ain't much money to try to do a major research project. But I was able, and I had friends back in the United States who had labs and people I had trained with. So I put together a proposal, and I wanted to test, we had enough money to screen 150 women who were coming into this university hospital for HIV care. Most of them had not received any antiretroviral therapy. They were coming in, they were fresh HIV victims, man. They were thin, they were wasted. Some of them had barely survived tuberculosis and meningitis. They were really sick, but we screened these women, and 30% of them, we screened them for cervical cancer. 30% of them had already had invasive cancer. And the other 60 or so percent had pre-cancer, and only I think 5% were normal. And so I went to the guy who had all this money for HIV, and he said, what do you think this means? I said, what it means is that all of these women that you're keeping alive and preventing dying from HIV, they're going to come back in your clinics, and they're going to have invasive cervical cancer. So they're going to truncate all this great work you're doing. And so that's when he sort of reached out to me and asked me what I think about coming to Africa and setting up a cervical cancer screening program. Well, I started talking to my colleagues here, and some of these guys, the guy that's to my left, Dr. Malindi Wana-Humuntu, has been my great friend and colleague. We, he didn't know anything about cervical cancer screening, pap smears or nothing. And this was in 2003. So next slide. Next slide. And so I asked, and I said, so what do you have here in terms of cervical cancer prevention services? So they had, for the whole country, there was one pathologist. Now this was a country of, at the time, it was 12 million people. One pathologist in a lab to serve 12 million people. That's insane. One cytologist. So there was one person who could read pap smears, and the next year after I first went there, he died. There were 12 gynecologists. I bet you can find 12 gynecologists in one office in one block, in 2 blocks in Washington, D.C. There was one cancer advocacy group, breast cancer group. There were no cancer doctors of any type. There was no chemotherapy, no radiation. No one was keeping any records on cancer. There was no cancer registry. And I got this crazy statistic that someone had where from the time the country had gotten its liberation from the British in 1964 up until 2002, something like 44,500 women had been diagnosed with cervical cancer. And only 300 of those women had been subsidized to go to neighboring countries to get radiation therapy. And so the other, 90% of those women just died with no treatment and no palliative care because there wasn't any morphine or anything around. And it's a painful death. If you're lucky, it will compress the tubes that carry urine from your kidneys to your bladder, and you become what you call uremic. And these poisons that you usually excrete from your kidneys through your bladder, they build up in your bloodstream, and you become comatose, and you don't feel any pain. So, but if not, you bleed to death at home. It can be a horrible, horrible, horrible death. So this was the way. This was what I found. This was the cancer, the cervical cancer, of just the infrastructure. This was what they had. This was what the British had left, and this was all that existed. And so that's why cancer was such a, you saw all these women, coming in with these advanced cancers. They hadn't been screened, and there was no way to treat them, so they were dying. Next slide. So when you think about that kind of stuff, when you see that, that's and you think about the beliefs, what people in the community will think about cancer. They will say it's fatalistic. So don't give me I don't want to come in to be screened for something because you can't treat it. Because all they've ever seen when you talk about cancer is someone who has this advanced disease. They come into the hospital and it may get operated on, they may not, usually you can't, and then they die. So this is a typical way that breast cancer presents itself in Zambia and a lot of the sub-Saharan African countries. Next slide. That's another one. That's just classic. I mean, we see it all the time. We see it every day. I was up in the DRC, Democratic Republic of the Congo, for the last 2 years, working in Dikembe Mutombo's hospital. We were setting up a cervical and breast cancer screening and early detection programs and surgical treatment. And I took this wonderful sister, Dr. Rhonda Henry Tillman, who's head of breast cancer surgery at the University of Arkansas, one of my former students. I took her up there, and she trained surgeons how to do palliative surgery, remove these things and try to do some plastic surgery. But as time goes on, as you start doing screening, you'll see women come in with smaller and smaller lesions that you can cure, but you can't cure this. A woman comes like this is usually already metastasized to her lungs and liver. But again, there are no services, there was no infrastructure to take care of women. So they would come in just when these things like this became unbearable. So when you talk about breast cancer in Africa, this is what you're talking about, as opposed to these little small shadows on mammograms that you find in the United States, except in some poor communities. Next slide. And the same thing with cancer of the cervix. I mean, here's at the top, you see the womb, which is when you get pregnant, that's where the baby is. Then you see all this white stuff down there. That's a cancer that has grown down the side of the vagina. And this is what we see when we would examine women in Zambia. They'd have these very advanced lesions. You can't surgically remove that. You can only treat that with radiation, chemotherapy and radiation together. And so that didn't exist, so they died. Next slide. And sometimes it would grow in between the bladder and the vagina and the rectum and the vagina. So you'd see women in the hospital and they just have stool and urine coming out of vaginas uncontrollably. Next slide. And so this is the way the cervix would look when you take that woman back into an examination room and you look, you'd see this big, massive, bloody lesion growing in her cervix, and this thing would have existed for several years. And just, you know, she'd come in when she just couldn't control the bleeding, or she was fainting because of anemia, et cetera, et cetera. But this is because there was a lack of any infrastructure for screening and early detection. This is what you saw, right? And you still see this in many places where there's no screening. And all this is the way it was in the United States in the 20s and 30s and 40s and 50s until screening, you know, mammography was set up and pap smears was set up. So it's not rocket science. I mean, you know, the risk factors are the same. They're no different in Africa. Well, there's a few differences, but, you know, basically if you can get women in for early detection, you don't see this. You catch it when it's very small or when it's a precancer. But if you don't have the infrastructure, this is what you see. And the women come in and they mostly die. Next slide. So again, the status quo at that time was death without access to screening or treatment. And, you know, I don't know how to describe this to you, but, you know, as a cancer doctor, you're always around death. But man, in Africa, death is just, I don't know. It's just, I'm not saying it's like running water, but people just die. People die all the time. They just die. You know, it's just death is just a part of the language. It's a part of what you see and what you experience every day. Even people that you know, you see them one day, next day they're dead. So it's poor nutrition, it's HIV, it's cancer, it's et cetera, et cetera. So it's you know, so again, here you go, churches making money selling coffins for the youth project. Next slide. And so the thing about death from breast and cervical cancer, and a friend of mine, a couple of friends of mine wrote this article, is really interested. For every 100 women who die from breast or cervical cancer, an additional 14 to 30 children will also die as a result. So you think about that. So these diseases are just not impacting the women, but they're impacting the future generation, right? So here's a mother, you know, lives in one of these areas, and here's her daughter. And imagine what happens to this little girl living in this kind of environment, and she doesn't have a mother like this to protect her, okay? And so it's not just her daughter or her children, it's the other children that are in her, what we call her halo, her sister's children, her, you know, her brother's children. And so these women women play a central role in life everywhere in the world, but it's in these environments, when they go out, it doesn't just hurt the economy. It's taking her life, but there are a lot of other things that happen. Most of these kids, if they're under 10, they don't finish school. Women play a key role in not just upholding the culture, but in trying to push the society forward. Very poor women, but they do just a Herculean job of this. And when they go out, this whole safety net, so to speak, just absolutely collapses. Next slide. And so what they die from, these kids will still die from the diseases that they usually die from, which are malnutrition, diarrhea, dehydration, measles, and acute respiratory infections. And those acute respiratory infections usually, you know, asthma is things that, you know, infections, and people burn a lot of charcoal and a lot of wood to try to stay warm in houses, so cholera. So they still die from these same kind of diseases, but just more of them die from these diseases because the mothers are the ones who make sure they get vaccinated, you know, measles, mumps, et cetera, that they go to school, that they try to live in as clean of an environment as they can, given the circumstances. So these women play just a incredible role. Next slide. Next slide. Is that all for that, Cheryl? And so when you start thinking about the living conditions of women, you know, I started thinking about this. You know, I was still trying to make up my mind about cervical cancer and what I was going to do, and et cetera. And I was, you know, thinking about the living conditions of women in these places. So it's a daily struggle for food, clean water, and clothing. Indecent shelter is really the norm. The trains are holes in the ground. This is no exaggeration. I mean, this is every day. The little protection from domestic violence. Early childhood marriage is the norm. Now, you know, since there's been an international push to end domestic violence and end early childhood marriage, some of these things have improved, particularly with African women becoming more prominent in politics. They're pushing to end these things. But, you know, sex can often be the only readily available means for generating personal income. So it's not necessarily sex for enjoyment, or she's what some people would, you know, say is a promiscuous woman. Man, she's out there trying to make a living. It was a wonderful paper that was done down in, I think it was Swaziland. It's called Eswatini now, where a nutritionist did a study, and she studied, you know, several thousand men, several thousand women. And the question was, what was it that made them engage in high-risk sex, you know, intergenerational sex? So a younger woman having sex with an older man, having sex, unprotected sex, no condom, having, you know, multiple sexual partners. And for men, there was no one single thing that turned out to be the most important variable, you know. But for women, she broke it down interesting. She said a woman wakes up in the morning, she looks around, and the first question is in her mind is, am I able to feed my family today? And if she can, she moves away from high-risk sexual behavior, some women. If she can't, then it becomes an option. I'm not saying women do this. I'm saying it becomes an option on the table for making income. So now it just tells you she's putting herself at risk for cervical cancer and for HIV. So they're stalked daily by malaria, HIV, TB, cholera, hepatitis. Next slide. And so when I started talking to people about cervical cancer screening and setting this thing up and what it was going to take to get women to come in, to get on the exam table, to put their legs up, to let you screen them and treat something that they didn't really understand. They thought it was witchcraft, or, you know, somebody had worked a hex on them because they had, you know, done something in the neighborhood. How were you going to get people? And everybody I started talking to, the doctors and nurses, they express what I call this spirit of lack. We don't have enough gynecologists. There's no money. The women won't come in to be screening because of myths and misconceptions. The husband's not going to let them come in. What do we tell them if we find a real cancer and we can't treat it? And then there was this woe is me. Well, if they have HIV, they're going to die of pneumonia, meningitis anyway. You know, or other age-related diseases. Why are you worried about screening somebody for cervical cancer? Why even bother? They're dead. And this is before there were a lot of drugs were available. Next slide. And so it made me think about this is 2003, 2004, 2005. It made me think about a conversation I had with this wonderful sister, Dr. Letitia Moja, back in 1995 when I was visiting a friend of mine, a friend of Tom Porter's, and James, the great late James Harris, Jimmy Hip. And I was visiting her. We were sitting out in front of something called the Renaissance Hotel. The sun was going down. We had a great afternoon sitting and talking. I had done some surgery with her at Medunsa Hospital. Badunsa was the Medical University of South Africa. It was the hospital that was set up by the Boers and the apartheid regime to train African doctors. And she said, and we were talking about cervical cancer. And she said, at the end of the day, she said, Groesbeck, we've had a great conversation this afternoon, but no matter how long we sit and talk about cervical cancer, you will never understand. Because we're talking about when we talk about this disease, you and I are talking about two different things. And I wondered for years, what in the hell is she talking about? A cancer is a cancer. The molecular aspects of the same. You know, stage 1 is stage 1, stage 2 is stage 3. But she was talking about the context that I just told you in which these women are forced to live, the poverty, the intersection between poverty and cancer. The things they have to struggle with every day, you know, food security, food insecurity, the infectious diseases, trying to take care of the children, not having enough food, having to negotiate, you know, husbands who may not understand, you know, certain things, and just the struggle. So it's not just here's a woman with the cervical cancer. This thing happens within a social context. You know, Tom Porter used to always talk about, you got to connect the dots. You know, you can't just separate these entities. They only make sense when you put them in a socio-economic or political economic context. And where did it all begin? And how did, you know, colonialism set this thing up? And why is it there are no facilities to provide for these women, and why are women living in these conditions, and why, what do they have to, what are they, in order just to survive, they're putting themselves at risk for some of these diseases. So you know, it made me think about the context. Next slide. And it also made me think about something that I heard John Henrik Clarke, the late John Henrik Clarke, say, as I was thinking about what I was going to do, because I was working at the University of Alabama at the time. And he said, you know, during the I think this was apropos for this moment. He said, during the 1960s, when we had people leaning back on their heels, listening to us, when we had pushed them back, we did not take advantage of that opportunity and do the hard work of building institutions. So when that period was over, and you know, we see what happened, then we didn't have our own institutions that would help us survive and keep going forward. We had to go back and rely on those same institutions that put us in the situation that we were in the first place. So it made me understand, you know, the importance of trying to take the knowledge that I had and do some of what we used to talk about in the 60s, but we didn't do it well, which was to institutionalize it, institutionalize your knowledge, institutionalize your skills. So once you disappear off the scene, they still go on. And there are other groups that do this very well. And he said that we didn't do this. And it's hard work. And it is not popular. No one sees you. But it's just, you just busting your butt every day. But that's what it takes to really build institutions that are going to last for any length of time. Educational institutions, political institutions, healthcare institutions, businesses, et cetera, et cetera. The heart, and I think we need to think about that now, because people are listening to us. We got people pushed back. I like to say the people that put you in the situation you in ain't, was it Audre Lorde? The same people ain't gonna turn around and save you. So you got to think about taking advantage of these opportunities to build institutions. And as someone say, we need to go back and listen to Brother Malcolm, and go back and listen to Garvey. And I know we don't like him very much, and he's maligned in the Black community, but we need to go back and restudy Booker T. Washington. Booker T had a lot to offer. He and George Washington Carver. So, you know, he had a certain way of doing things, but if you take that stuff away and look at what he did, an institution still down there, Tuskegee, and it's turning out a lot of people over the decades. So we need to relook at some things. Next slide. And so, so I decided to go, and I decided to stay in 2005, and I decided to, as Booker T. Washington said, cast down your buckets where you are. And so I went in 2005. What I talked about was what is to be done. These are some of the things we have done. We set up a cervical cancer screening program that Janine talked about. It's institutionalized. That program now is run by the Zambian Ministry of Health. It is a part of the Zambian Ministry of Health. So the only cervical cancer program I know that was started by an NGO and individual, they run it now. We just started something where a nice little program where we took breast cancer screening and treatment out into the community, into primary care centers, so women can access these things. It ain't rocket science, man. Women can't travel to these big comprehensive cancer centers. You got to decentralize the services. So I got some money from the Coleman Foundation and sent a couple of women can get educated about cancer, breast biopsies. They get the pathology read, and they can get the surgery all in a hospital that's near them, and that's going to be expanded. We set up a surgery program where now we've trained 4 or 5 young Zambian doctors how to perform this complicated gynecologic surgeries. And women come in with cervical cancer, ovarian cancer, blah, blah, blah. And then we have a nice research platform where we working with the National Cancer Institute, develop a cervical cancer screening using artificial intelligence, and then some clinical trials, comparing various ways of treating. And then we also always are trying to train young African scientists. I mean, Africa is some bright kids here, and they need to be trained to write their own research projects and to figure out what they want to do for their own countries. They don't always need to be getting money from Americans and Europeans, and they need to develop, because it's their minds, it's their country, and that's the way their knowledge is going to be institutionalized, and it keeps them from running out of the country to Europe and Australia. And it's like Jim Harris said, you need to go somewhere where somebody loves you, and home is the best place. So that's what we've done. That's how I got there. And that's what, that's the way that's been my experience with breast and cervical cancer, which are the 2 biggest cancers on the African continent. Next slide. I'm gonna let y'all take a breath, and I'm gonna have someone to turn this I want to pull up another set of slides. So give me 3 minutes, take a deep breath, and I'll be right back.
Yeah. While we're waiting, I don't know about you, but this has been an intriguing presentation. Obviously, a lot of information that some of us were not aware of, and those that are, you've seen the progression. You've seen over the years how cervical cancer and breast cancer screenings, even in the United States, how it truly has saved lives. So when we say those words, there's a lot of meaning behind it, right? And without the screenings, what happens to our bodies, what happens to our families as a result of our not being there, right? So
while we're waiting, we can ask people to put their questions in the chat.
Yeah,
while we're getting ready to tee up these next set of slides.
So you can't see my slides, can you?
No.
Good. That's good. I don't want you to. So let me just I want to make sure I get these numbers in. I want you to understand what's happening with this so-called global epidemic of cancer. So, Africa is dealing with 2 epidemics of diseases. So there were always these infectious diseases, right? Malaria, TB, HIV, cholera. those kind of things. But now side by side with that is this raging epidemic of what they call non-communicable diseases, right? Diabetes, hypertension, obesity, cancer, some mental diseases, right? Mental disorders. So now you take these economies, which are already been struggling with the infectious diseases, and now you dump these non-communicable diseases on top of it. Now just think about diabetes and hypertension and obesity, overweight. You know, those things are chronic. You rarely cure people of those. So it's expensive to take. I mean, that's one of the things that's breaking the American medical system. It costs a lot of money, you know, the insulin, the antihypertensives, and people have strokes and blah, 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 blah. And cancers, you know, breast cancers, colon cancers, this, you know, radiation, chemotherapy, complicated surgery. And the weight is incredible. So, but if you look at this, and this is happening, this is in the 21st century, cancer is thought to be is going to be the single most barrier to increasing life expectancy in every country in the world. So it's a big problem. Now, in 2018, there were 18 million new cases and 10 million new deaths from cancer across the globe. 18 million new cases and 10 million new deaths. Now, by 2040, that number is going to increase by 70%, the new cases and the deaths. Now, what's interesting is that most 70% of the new cases in the next 20 years and 70% or 7 out of 10 of the deaths are going to occur in places like Zambia, in low and middle income countries, Asia, Africa, Latin America, right? And most of these are going to be lifestyle disease, lifestyle cancers, cancers of the breast, cancers of the colon, cancers of the lung from smoking, cancers of the prostate, which have been associated with diet and processed foods and whatnot. And so as these countries become westernized and adopt the Western way of living, they are also incurring the cancers that occur within that kind of lifestyle, processed foods, et cetera, et cetera. They're moving away from their traditional diets. They're moving away from physical activity. I mean, people in Africa walk all the time. So now people are sitting at desks, you know, they're drinking a lot of sweet drinks. They're eating a lot of processed food. They don't eat a lot of fiber. I mean, back in the day, in the 40s and 50s, you rarely have ever heard of anybody in Africa developing colon cancer because they ate 50 grams of fiber a day. That's a lot of fiber. You got to wake up in the morning thinking fiber. You got to be eating just vegetables and fruits and sweet potatoes and candy. I mean, cassava. I mean, there's a way to do it. There's a way to do it. But so what the fiber does is it just doesn't increase the transit of these toxins through your gut, but it also changes the nature of the microbiome, the kind of bacteria that are in your gut. And people now, more and more scientists are coming to realize that this microbiome is a very important risk factor for developing cancer. There are healthy microbiomes and there are unhealthy microbiomes. And it all depends on what you put in your mouth and physical exercise, et cetera, et cetera. So, you know, even the American Medical Association says that about 1/3 of all deaths from cancer are due to human behavior. You know, whatever it took for you to increase your body mass index above normal, low fruit and vegetable intake, lack of physical activity, tobacco use, and alcohol use. Now, when you look at the continent, the two most prevalent cancers are cancers of the breast and cancers of the cervix, okay? And those are increasing rapidly. Now, let me just tell you a little bit about cancer of the breast in Africa. The actual incidence or the new cases per year are on the low side compared to the Western world, but the death rates are the highest in the world. But the incidence of the new cases are increasing again because of lifestyle, but the death rates are among the highest in the world. So if you get breast cancer and you're living in Africa, your chances of surviving 5 years is about 30%. You know, so if you had 100 women and they had breast cancer in Africa, 5 years later, only 30 of those women are gonna be alive. And there's some recent data on that. There's a study called the ABCDO, African Breast Cancer Disparities Outcome Study, run by scientists at the International Association for Research on Cancer, which is the WHO's research agency in Lyon, France. And they took 5 different African countries. Zambia was one of them. And we followed for several years the pathway of just the path of women who were diagnosed with cervical cancer, with breast cancer, to figure out where they fell off the track, what was the thing that caused them to deviate from going from this clinic where they got diagnosed all the way to the end of treatment. And some of it was their beliefs in the traditional healer. Some of it was the family members saying, no, don't pursue this therapy. Some of it was transportation. Some of it was just the hospital took too long to get the biopsy, or it took too long to get the biopsy results. Or when they came in to get the radiation and the chemotherapy, the machines were broken down. So there were delays all along the pathway. Caused by some of these women, what they call women-centric issues, and then some were system-centric issues. But whatever, it resulted in a significant of those women not getting treated, and so they die. And again, they come in when these diseases are very advanced, like that big breast cancer I showed you, the advanced stage of disease. And then there are all these barriers to receiving and actually complying with treatment. Now, this is interesting about breast cancer, because breast cancer, as I told you, the rates of of breast cancers are fairly low in Africa compared to the rates of new breast cancers in the Western world. But it's changing, and the rates of breast cancer in places like sub-Saharan Africa are increasing. And why is it changing? Well, think about what we know that are the risk factors for breast cancer. One is menstruation. If you have an early age at menarche, when you start your menses, and a later age when you have menopause, it means your breasts are exposed to a lot of estrogen because you're ovulating all the time. So some people think that it's this massive ingestion of processed foods that are leading to girls going through puberty at very early ages on the continent of Africa, and also having late menopause. Now, the other one is reproduction. For decades, there have been various organizations who have said that their effort is to try to improve the lifestyles of African women, to give them a chance to go to school, to become more than just women who just have babies. And so they've been preaching delaying the age of your first child, not having babies maybe at all, and having fewer children. And what we know is that the more children that a woman has, and the earlier she begins to have children, and the more children she has, and the younger she is when she begins to have children, the lower her chances of developing breast cancer, right? And it all has to do with, because when you're pregnant, you're not ovulating. So again, this exposure to estrogen. Then there are all these exogenous hormones, to prevent pregnancy, the Depo-Provera shots and oral contraceptives. And then there's, again, the change in lifestyle. So there's greater weight gain, there's weight gain during adulthood and childhood, and body fat distribution. So a lot of this has to do as you're watching this African woman as she moves from her traditional way of living and adopts a more westernized way of living. She's beginning to develop these diseases that are also common in the Western world. Now, let's talk about cervical cancer. Every year, there are about 500 new cases of cervical cancer and about 300,000 deaths. In the next 10 years, that 500,000 is going to go up to 700, and the deaths are going to go up to 300. That's every year. Every year, you have women dying from a preventable disease, right? Now, the thing about it is that most of the cases of cervical cancer, 80 to 90% of the cases of cancer of the cervix and 80 to 90% of the deaths occur in poor countries, Africa, Asia, Latin America. In Africa, in sub-Saharan Africa, cervical cancer is the second most common cancer and the most common cause of cancer-related death. Whereas for breast cancer is now the most common cancer diagnosed in sub-Saharan Africa and is the second most common cause of death. Cervical cancer flips around. It's the second most common cancer diagnosed in women, and it's the most common cause of cancer-related death. So between those two cancers, it accounts for about 50 to 60% of all the cancers that women in Africa have, and about the vast majority of the cancers, the vast majority of the deaths. About 1/3 of all the cervical cancer, 1/3 of the cervical cancer deaths occur in sub-Saharan Africa. So it's a killer. So what puts women at risk for cancer of the cervix? Early sexual intercourse, as I told you, early marriages, early childhood marriages, multiple sexual partners, or a sexual partner who has had multiple sexual partners, multiple childbirths, poverty, no opportunities for cervical cancer screening, and a biggie is HIV infection. So you got these big two diseases that thrive on, that promote one another. Women who have cervical cancer are at higher risk of developing HIV because they are bleeding, the cervix is raw, and if she has sexual intercourse with a man who has unprotected sexual intercourse with a man who has HIV, that's the way it can enter into the bloodstream. On the other hand, women who have HIV are at higher risk to develop cervical cancer, okay? Because it causes that, because the immune system is weakened and it can't get rid of the virus, this HPV virus that is sexually transmitted. Everybody who's ever had sex has probably been exposed to the HPV virus. But if you have a strong immune system, it will clear that virus out of your pelvic area in 18 to 24 months. But if your immune system is weakened from HIV or stress or excessive alcoholism, poor diet, et cetera, and for some other reason we don't know, that HPV infection persists. And once it persists, that's when the clock starts to tick. So that's where the epidemic is in breast and cervical cancer. And so much of it, again, is related to poverty and the westernization and Africans moving away from their traditional ways of eating. And, one of the things I want to talk about the next time I come on is what I call the African diet. And one of the things we're trying to do here is to figure out how to promote the African, what we call the African village diet. It was healthy. Africans figured it out, man. They figured out how to eat healthy. Greens every day, lots of fiber, lots of wild fruits and berries. They figured it out, and they're giving it up. And I'm gonna say this, and then I'm gonna open it up for questions. Now you got to put your head screwed on right to really understand this, because it floored me when I heard him say it. So I have a great friend who used to be the Minister of Health, and then he became the permanent Secretary of Health here in Zambia. And now he's the CEO of one of the big private medical schools. So he summoned me to come see him the other day, and I was sitting there with two young ladies that work for me. And he turned to them and he said, because he's talking to me about trying to start a wellness center here at the university. So he said, I'm going to tell you all something. He's looking at these young Zambian kids. He's Zambian. He said, the thing that has saved, now don't go out and repeat this, because people go get it wrong. He said, the thing that has saved the African from all of these diseases, these so-called Western diseases, is starvation. He said, as soon as y'all get your hands on some money, when the economy gets better, you're going to find yourself dying like flies, because you're going to be dying of diabetes, hypertension, because all you're going to do is go to McDonald's and Chuck E. Cheese and all these new places that are coming. You're going to eat yourselves to death. He says starvation has helped you because it's low caloric intake. Well, I wouldn't go so far as to say starvation, but what I would say is that we know that, what do they call it when you fast? Intermittent fasting.
Intermittent, yeah.
Low caloric intake, high nutrient, low caloric foods such as fruits and vegetables and beans and grains. That's the way to go. And I do understand what he's saying is that now's the time, as he said, now's the time for Africans to educate themselves about the value of their rural tribal diet, and to go back to that diet, or else they're going to find themselves, with so many of these chronic diseases that. And he turned and said, he said, they're dying. You're going to be like your cousins over in the United States with all these chronic degenerative diseases. So anyway, that's all I want to say. And thank you very much. And I'm open to questions, and I'm looking forward to the Institute for inviting me back so I can talk about HIV in Africa, and also talk about the relationship between food and cancer. So thank you.
We absolutely will have you back. We are so happy today. Thank you so much. You really took me back, because I visited Zambia in 1999, and I visited the copper mines in Kitwe, but I didn't have the perspective and the commitment to women's health that I have now. So I didn't see what you just brought to all of us, which is amazingly eye-opening. So at this time, I'd like to open the floor up for questions. I'm sure there are a lot of questions.
Yeah.
If you kick off the questions with my own questions, I can take
and
that.
Cheryl, there are several that were in the chat room for a while.
Okay.
Hey, Cheryl, before you talk, is Tom Porter on this line?
Tom Porter is on the line.
Tom Porter, where you at?
Tom Porter, I will unmute you. Tom Porter. Well.
Okay, all right, go ahead.
He's here. I see he's in here.
Yeah, all right. Text him maybe, Cheryl, if you can, and let him know that we're trying to reach him. And in the meantime, I will read one question, Cheryl. One of the questions is, are prophylactic gynecology and breast surgery considered? And are these cancers mainly genetic?
So, I think most scientists would tell you that 5 to 10% of breast cancers and colon cancers are genetic. The rest of them are either lifestyle or some other factors of which we're not aware at this particular point in time. But there are genetic tests you can get if you had, if people in your family have these cancers, and you have these things called BRCA1 and BRCA2, it increases the chances that you You know, if you got breast cancer, the chances that you have it in the opposite breast or from the ovary, and if you add it in the ovary or the lining of the uterus, you increase the chances, excuse me, that you may have it in the breast. And then you got offspring you need to think of. But we don't have genetic testing on the African continent. They probably have it down in South Africa. I bet you could probably get it in some places in Nigeria, but that's a real luxury. It would be interesting to begin to, and just, I mean, people just don't know why their relatives died. You know, people just die at home because no medical care. But I think it's coming. It's coming as the science moves across the water, it'll come. But more by and large, I think most of these cancers that affect us are by and large not genetic.
Thank you. And thank you, Dr. Parham. And then there's another question, and there are several questions within the question. I'll read them, and then of course you decide how best to address them. Have you seen the screening compliance rate change? What is the rate of compliance? Are these services taken into the community villages, or do the women have to travel for screening access? And what about a vaccination for cervical prevention? So working back from thank you.
Yeah, I think those are great questions. They are really great questions, and they are things we had to struggle with. So, you know, when you're in any situation, you need to let that situation talk to you and tell you what it is. Let it define itself. You know, it's like if it's almost like if you buy a piece of land, I think, and you need to look at it before you start trying to redesign it. You know, where do the birds fly? How are the trees growing? Why are they growing the way they're growing? What are the patterns? And that's what I think I had to understand. I had to slow down and watch and learn the patterns of women, because people say, oh, women are hard to reach. They ain't hard to reach. They can find each other all the time. You know, I can find you. Someone can find Ms. Mbewe, but she moves in a different way, and you got to figure out how she moves and why she moves, and why she would make the decision to go to your clinic, even if you or not go to your clinic, and you can put it right next door to her house. She may say, you know. And you say, well, it's all about availability. It ain't just about availability. Availability is important, but it's more than that. So we had to listen and learn from women themselves, particularly the nurses. I mean, I work with a group of nurses, and they are just incredible. They come from these neighborhoods. They know what women think in these neighborhoods. They know the myths, the mythologies. They know what the men think. They know how women need to be treated when they come into these places with the ultimate. I got this quote from one of my nurses when I was at Charles Drew University. I ran across it last night. Her name was Mildred Knox. And she told me this in the 80s. She said, Parham, if you treat a woman with dignity, respect, and a certain degree of kindness, she said, if you put that in your clinic, any dispossessed woman will access that service if you contextualize it that way. Because she needs to feel like she's respected. You need to educate her. You don't need to make her feel ashamed. She needs to feel confident that whatever you find in her body stays between the two of you. Your service needs to be high quality. It needs to be the best you can deliver. You need to be there when she comes, not have her waiting all day. So that was one thing we did. The other thing was we had to go in the community and dispel the myths. And one of the things we did was just show pictures. Because people say, well, cervical cancer is witchcraft. And we said, man, you just show pictures. Here's that same picture I showed you with all that blood. You said, this is cervical cancer. This is the way it looks. Now, third thing we did was we elicited the help of the people who control the market share of medicine on the African continent, and that's traditional healers, right? They got 60 to 70% of the market share. Women come to them first. So we asked them should we set up the clinics and how we should offer things and set up a relationship with them. And so we listened, and we would meet every week, and if somebody complained or women didn't seem like they were accessing, and then we did a big study in one of the clinics that we set up in one of these very poor areas, and women weren't coming, and we went around and tried to figure out why, and the answers were, well, I don't like that cold instrument that you're putting inside of me, and you trying to sterilize me, or people say if I go to the clinic that means I have HIV, or that I have had sex with some other man's wife. So all of these things had to be put into the messaging that we carried. And we went to the churches and the schools, and women who had cancer themselves who came to get screening. We let them carry the messages. And then as far as taking the services to women, we put the screening clinics in the smallest health clinics that we could. We went from the university all the way down to these, what they call health posts, where there may be no one in there but what we would call a maid, or I know people don't call people maids anymore. There's a new name for it. And a community health worker and a nurse. So we took the services to the people. And then for the very rural people, we set up something called we set up a relationship with the tribal chiefs, because women live in these chiefdoms. So we went to see the tribal chief, explain to the tribal chief what cancer was, why it was important to get screened, got his or her buy-in. Then they would summon the women and men in the community, and then the nurses would go out and screen for a week. And that's really turned out to be a big thing. The government really loves that. So, because it respects, this old tribal tradition, which exists side by side with the modern quote unquote democracy. Because, if the chief doesn't want you to be elected president, you ain't gonna get elected president. So they're very powerful. So all those things. And then the government has adopted the HPV vaccine. So young girls are being vaccinated. They did their first round last year. They vaccinated, I think, 250,000, and they're coming back this year, giving them another dose. And science looks like maybe one dose may do the trick. And what the vaccine does, it prevents the young girls from getting HPV infection. So that combined with screening is the way to go, because if you already got the infection, the vaccine is not going to help you. So we did all those things. So I think those are very important. We learn and we listen, and I think that's why the program has been so effective, because it's based in listening to people in the neighborhood. Being a Black man has helped me tremendously because I know how people feel. I know exactly, how Africans feel when they talk about someone coming into their communities that's a foreigner and telling them what to do. And I'm like, and I've gotten some pushback sometime as an American. And I'm like, look, I feel you. I understand. I ain't got no problems with it. Yes, I'm an American, African-American. I originally come from the continent, but I understand. So yeah, I'll step out of the way. I know exactly how you feel. So I'm very sensitive to ownership, and Africa's wanting to own their own intellectual property and own things that they have.
Dr. Parham.
Yes, sir. Yes, sir.
How you doing?
I'm doing good. I feel complete now that I've heard your voice.
Yes, sir. You're doing good. You're doing good.
Well, we're trying, Tom. Great to hear from you.
Yeah, I'm glad you could take the time from I know your busy schedule.
Well, things are slowed down now because of COVID, so I don't move around as much as I used to.
Yeah. That's probably wise.
It is. And
so Janine, are there any other questions in the chat? I do have a question.
There was just a comment and based and thank you, Tom, for speaking to Dr. Parham, your friend. There's a comment that basically complements just what Dr. Parham just shared with us. She says, yes, the compassion component is the first topic of conversation when women share information with each other. We are guided by our emotions. If we feel safe and heard you, and that they heard you and have our trust. So
absolutely. And you know, my whole idea when setting up these clinics was that a man should not be within 1,000 miles. That this should be a thing between women. And so it's nurses, female nurses talking to female patients. And I don't need to know what goes on in that conversation. I just know it works. And so, you know, I don't need to analyze it. I don't care. I ain't gonna understand it anyway, because you women.
So with that, let me ask a question though then. So just to make it relate to things that go on in the United States, you answer this in a way, but what is there that compares to sort of a public health kind of campaign? I know that self-care in the United States means going to get a manicure because you're stressed. But in terms of self-care, what is taught so that women, when they leave your clinics, they're able to continue to take care of themselves? And then the other question is, what is the man's role? We talked about women and their influence and impact on children, but what is the man's role in the community and how does that play out in Zambia?
So what the nurses do, they stress a couple of things. They teach women how to examine their own breasts. They call it breast self-awareness, right? And it comes under the heading of know your own breast. Know how it looks when it's normal. So if it's big on one side now, you got a lump that you never had, or it's tender, or it's blood, you know, whatever, then you need to come back, right? Not that that has ever been shown to decrease death rates, but it gives the woman some control over her situation. And actually, you know, as my breast cancer friend tells me, most women are the ones who find their own lumps. You know, they come in telling you, I felt something here, I felt something there. So we do that. And they also tell them not to douche. There's a big history of Zambian women douching themselves with their fingers. And we try to make them understand that the secretions, the natural secretions, have substances in there that will kill viruses, kill yeast, kill bacteria. And so they wash on the outside, but don't wash the inside because you're harming yourself. We try to tell them to, you know, make sure they don't have sexual intercourse with someone who's HIV infected, and if they don't know, to use condoms. They can't always do that. And I think, and to come back, how important it is to come back periodically for an exam, and our doors are always, so those are the two things. And also healthy eating, if they can, you know, fruits, vegetables, things that are very cheap to eat on the market, et cetera, et cetera. And we need to do better about that. Men, Cheryl, I think men can be very supportive. They don't need to stand in the way. Men who haven't been circumcised can get circumcised to decrease the chances that they're going to get HPV infection. They can do that, and just be supportive of women when they come to get screened, and if they need treatment, you know, help them go and get the treatment. After treatment, we ask women not to refrain from having sexual intercourse for 2 to 3 weeks to honor that. We've had to sometimes write a prescription because she goes back home. Why you can't have sex? You got another boyfriend? Blah, 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 blah. So just to be understanding and to be supportive and to come to the clinic and participate if your wife or your significant other wants to allow you in the room. That's her right. So just to be supportive and to understand and not be a bonehead about these things. And not to, you know, try to, you know, support the efforts to end childhood marriage, support the efforts to end physical abuse of women. all those things that men are doing, that men do that. And I don't think men were born doing this, right? I don't think that's genetically a part of what a man is. There's a social, political, economic context to that too. I'm not saying it's excusable, but you know, my grandsons didn't come out of their mother's wombs wanting to, you know, slap a woman upside the head. They didn't. That's a learned behavior. So we, you know, we need to, why is that? Why is it so prevalent in these societies? How much of it is cultural? How much of it is, you know, from deep poverty and social oppression, and men not getting an economic break? You know what? It's just, man, it's deep. It's deep. So anyway, I think, yeah. Go ahead.
I like to piggyback on Cheryl's question. You know, having 5 sisters and 5 daughters. I grew up in a time when men would not go to the store and buy feminine products. They would give a note to the clerk in the store. My father wouldn't even go with a note. So it fell upon me to do that. That Cheryl's question about the role of men, I don't know if we ever talked about it, Groesbeck, but I was at one time diagnosed with breast cancer.
I remember
that. I had to get a mammogram and all of that. Of course, I was the only man in there, and fortunately, it was either a false alarm or I went on a 14-day cleansing fast under a doctor's direction, and he said that we would look at it, and of course we did look at it, and there was nothing there. But several things is, what is the role of men in terms of, because if somebody in your family has cancer, it impacts everybody.
Right.
The other thing is that breast cancer, although it's rare, but it exists. Richard Roundtree, the actor, had breast cancer.
That's right. No, I think you're right. I mean, you know, men need to understand that they can get breast cancer, Tom, and if they feel not, they should know their breast also. You know, look in the mirror, knots, bumps, tenderness, and you know, being supportive. You know, I was 10 years old and my mother was diagnosed with breast cancer, and this was, man, back in the 50s, and there were no support groups at all. And I just remember what she went through. I never asked my father what he thought about all of that and how it impacted him. He didn't leave her. He never thought about leaving her. But I just know the family never was the same after that horrible surgery she had. And at the time they were doing those Halstead radical surgeries where they scraped, it would cut down to the rib cage. And she was a beautiful woman. I mean, everybody thinks their mother's beautiful, but my mama was Holly Berry, Lena Horne, beautiful, man. And it just wiped out her whole self-image, and spent a lot of time crying and praying. But, you know, she lived to be 105 years old. You know, so yeah, you know, it impacts the kids. You know, my brother passed away before he and I could talk about how that impacted us as children and as brothers and families. But I just remember, you know, a sort of coldness sort of entering the house, and was never the same after she had that surgery. She's still a nice lady, still a calm lady, whooped my ass all the time, but I deserved it. But so yeah, there's, it is a family, it's a family disease, and that's not something we have addressed here on the continent very well at all. That's a big gap. I'm glad you're bringing that up. Survivorship that's all about survivorship, because she doesn't live as an individual. She lives within a context. She lives within a family. She lives within a community. She lives within a country. So all of those things are impacted when she's impacted. So it's a great question to raise, to think about.
It's interesting because I think in general, even within our organization, IAWH, giving some thought to the impact of cancer in the entire household, and and having that opportunity to address it in different areas. And you hit it spot on, Dr. Parham, survivorship, and having discussions around survivorship, what that actually means. And I just wanted to mention that you also talked about, I know we're a little bit past 10, and I thank you all who are still here, to talking about you talked about the African diet and how to promote the African village diet. And often, because you're starting to see how those rates will continue to increase, the closer that, that women or, feel that they want to start feeling more westernized or being more westernized in the way that they live. But I love that point that you made, how important it is for us to remember what is, because you talked about nutrition, food and nutrition and its correlation to cancer. So for us, on this side of the lake, for us to really remember how important that is, our nutrition as well. Any additional questions for Dr. Parham? It is at 10:05. If you have other questions, please, Cheryl, is everyone unmuted if they wanted to ask another question?
I can unmute everyone, but everyone can unmute themselves too.
Yeah.
Okay.
It looks like I don't see any additional questions. I don't see any additional questions come up in the chat. Cheryl, Is there anything else?
No other questions here.
Hi, this is Dr. Bercy. It was a fantastic and Sharon, I get with you. I got your email, and thank you so much to Dr. for calling me and texting me and telling me that this will be a fantastic presentation to listen. And I'm you, please, and thank you. Thank you very much.
Okay.
Thank you, Dr. Bercy.
Thank you, Dr. Bercy. Dr. Bercy addressed endometriosis and
uterine fibroids.
And uterine fibroids with us, Dr. Parham, several weeks ago.
Oh, I'm sure that was great.
And hopefully she's coming back to talk a little bit more about endometriosis. That was such a popular topic.
Yes, I will. I'm planning on emailing you guys this week. I had a pull muscle and I couldn't lift up my arm and write or do anything. It was my whole right side was not working, and my PCP told me that it will take a good 6 weeks, and I'm on my 5th week right now. So hopefully by next week I'll be good to go. The pain was like worse than contractions. So I was
my goodness.
Yeah.
Well, take care of yourself.
I am. And again, it was a fantastic presentation, for the data from Zambia. And so it's great. And I look forward to hearing your talk about cancer and nutrition, because that's one of my interests as well. So
great. Fantastic.
Thank you.
Nice to have met you. Nice to meet you.
Absolutely. And you, everybody have a blessed weekend, and stay safe.
Thank you so much, Dr.
Thank you.
Thank you.
See, bringing people together.
And this is Dr. Clayton. I'd like to thank Dr. Parham for an outstanding, comprehensive presentation, and we look forward to reconnecting very soon.
Hey, Linda Clayton. Okay, thank you. Thank you for coming on. Thank you so much. Looking forward to seeing you again. Thank you so much for your support.
Thank you so much.
The center lives.
Yes.